Welcome. Welcome to an event jointly sponsored by the Lewis Leavitt Distinguished Lectureship and the One Book, One Campus program designed by the Interprofessional Education Group to bring all the learners and teachers on this campus together around a single important theme. It's not loud enough? Okay. All right. I'll just lean into it a little bit more. This year, the one book is An Unquiet Mind by Kay Redfield Jamison, and the theme is the indivisibility of mental health from health and the centrality and importance of that. I want to thank a couple of people before I roll into this introduction. One is the chancellor of our campus, Don Elliman, who actually signaled the importance and centrality of this theme for this campus several years ago and has consistently made the kinds of commitments that chancellors can make to making sure we remember how important this is. So thank you, Don, for that. It's going to redefine this campus. It's going to cause us to be distinguished by the importance that we ascribe to mental health. I would also like to thank Suzanne Brandenburg, who is on point in the lead for the Interprofessional Education Initiative that actually put this idea in my lap in the first place. So thank you, Suzanne. Lewis Leavitt was born in 1896. He went to vet school here in Denver and graduated in 1920, so he started out taking care of cows. Then he went to medical school, graduated in 1927, and for 40 years until 1967, he practiced general practice in the city of Denver until his retirement. He lived until 1976, upon which time he bequeathed an endowment to the Department of Family Medicine. He created a distinguished lectureship. Since that time, we've had about 70 speakers come to this campus to educate us and inspire us and edify us and otherwise make us bigger and better than we were. We've had surgeons general come under this lectureship, presidents of the National Academy of Medicine, presidents of local and national health foundations, international speakers in many fields of health education, healthcare, and medicine. And I dare say that today's speaker is surely among the greatest of those. You're in for a treat. This afternoon, Dr. Kay Redfield Jamison can fortify us with as a common body of would-be healers with the knowledge that the illnesses we're called to treat, as terrible as they can be, themselves contain life. This one in particular, manic depressive illness, is somehow tangled up with some of the highest of human accomplishments, as well as with destruction and death. It's a very complex and complicated and difficult to grasp disorder. And the instruments that we use for treatment of this disorder are blunt. We've got life-saving drugs. They can not only tamp down the kind of wild, violent, thrashing madness that is associated with this disorder, but they can also kill the spark of genius that occurs sometimes in association with manic depressive disease. It can kill imagination, they can kill impetus, they can kill creativity. So we need to become sensitive and nuanced in our understanding of illness in general, and this illness in particular, in all of its complexity. And we also need to become equally sensitive and nuanced in the use of the agents, in the use of the treatments against illness, which must be equally used with a light and sensitive and informed touch. So Dr. Jamison is a clinical psychologist. She's the Dalio Professor in Mood Disorders and Professor of Psychiatry at the Johns Hopkins University School of Medicine in Baltimore. She's also an honorary professor of English at the University of St. Andrews in Scotland. She's the recipient of a MacArthur Award. She won the Sarnat Prize that the Institute of Medicine, now the National Academy of Medicine, awards each year to the person who has done the most good for mental health in the world that year. And the list goes on. I'm going to stop because she's probably bored by hearing all of this stuff, and you can read about it if you care to. She's written several national best-selling books about the experience of living with manic depressive illness, about suicide. She's written about grief. She's written most recently a magnificent psychological account of the life and work of the great poet Robert Lowell. And I just can't help myself but to recommend with all my heart that book to you. It just went through me and changed me and scared me and made me better. As a clinician, Dr. Jamison has given us the operating manual in the form of the standard textbook on bipolar disorders for how we understand and help manage patients who have manic depressive illness. So she speaks to us from the perspective of clinicians and healers. But then she moved to a different point of view and has shown us from inside herself and from inside ourselves what it's like to live with a mind that is subject to wild flights and deep dives, and what this has to do with imagination and impetus and creativity and genius and our basic capacities for accomplishing great things, as well as the terrible costs of delusion and ungoverned grandiosity and self-deception. So it takes incredible courage to reveal these terrible gifts within yourself, and uncanny talent to do so with such clarity and beauty and brilliance. You know, earlier I said Dr. Jamison is a clinical psychologist. She's also an exceptionally gifted artist. And she writes in a way that just transports me and just changes me forever. And I do believe that this afternoon we are in the presence of genius. And it is a privilege to be here. And I hope you will join me in welcoming Dr. Kay Redfield Jamison.
Thank you. Thank you so much for the introduction. Thank you most particularly for the kind words about my book about Robert Lowell, which was heart and soul for many years to write. And I like it the best of my books, so I suppose it's particularly meaningful. I'm delighted to be here at this campus, which is a very innovative series of ideas and concepts, obviously, and the integration of people who study and treat all kinds of illnesses, and then the integration of the problems of depression and anxiety and addiction and so forth, and incorporating that into the medical and clinical programs. I think it's a wonderful idea. I also think the idea, not just because you chose my book, thank you, but I think the idea of one book, a common text, whatever the text is, to share and discuss is a great one. I think it's a terrific idea. Books are going a little bit the way of a dodo in this day and age, and I think it's nice to be able to talk in common about it. So thank you for inviting me. I thought I'd start by just talking for a few minutes about the nature of mood disorders, about depression and bipolar illness, once called manic depressive illness, still called manic depressive illness by some, but bipolar illness being a history of not only depression, major depression, but also highly agitated, perturbed, high energy, high voltage, irritable states often associated with verbal fluency, aggression, a very interesting constellation of symptoms. And on occasion, and in the case of Robert Lowell, was discussing when he started getting manic, he wrote poetry, and it was the poetry that defined him in many respects. But it was after a certain point when he got too manic, it went into gibberish, and it was then the many, many months after he was well or depressed that he then shaped that into poetry. But everything goes into overdrive in mania. So I just want to talk a little bit about what they are and what we know about them, which is we know a lot. And I think that one of the great misconceptions about mental illness in general is it's one of these kind of touchy-feely, squishy fields, not terribly scientific, not much scientific basis to them. The fact is we know a lot about the brain. We know increasingly a lot about the genetics of these illnesses. And we know a lot clinically. And mania has been observed and depression have been observed since long before Christ. And so people have been writing about, the ancient doctors wrote about these illnesses. These are not new concepts. So depression and bipolar disorder are characterized by major disruptions in not only mood, we think of them as mood disorders, but also in energy and sleep and behavior. And one of the reasons why depression most often comes first to family practice or general medical clinics is because people have sleep problems or they have problems in sleeping too much, sleeping too little, or energy. They simply feel sapped of energy and feel like they have some sort of viral problem or other kind of medical component. Very importantly for this kind of setting, bipolar illness and depression are illnesses of youth. They first hit in the late teens or the 20s, usually. And unlike cancer and heart disease, which first occur much later in life, mania and depression hit early, hit hard, and they're chronic illnesses. So once you've had one episode of mania, for example, you've got the illness for life, and you can keep it at bay. You can certainly treat it. They're effective treatments, but the illness does not go away, which means that these are unusually long illnesses, cause a lot of suffering if they're untreated. Mood disorders are also very common. This is not one of these mondo bizarro diseases that nobody gets and everybody writes about. Depression is really, as often said, the common cold of psychiatry. Depression is very, very common. And we tell our medical students at Johns Hopkins, look, when they first come in, look, a lot of you are going to get depressed. You're at the age of risk. It's in the cards. That's what happens. The question is what you do with it. And we will do everything possible to get you well. There's every reason to believe you will get well. But what we can't tolerate is not getting treated. We can't have impaired young doctors. But, if you try and exclude, depression from clinical communities, you would have not so many clinicians. So about 1 person in 100 will get the classic form of bipolar or manic depressive illness. That means the severe form of mania together with the severe form of depression. But another 2 or 3% of the population will get milder forms of bipolar illness. And nearly 1 person in 5 will have at least one episode of clinical depression. So this means if you don't get depressed or you don't have depression in your family, you're going to have a friend or a colleague who gets depressed. Depression and bipolar illness are genetic illnesses, particularly, this is true for bipolar illness. It is one of the most genetic illnesses there is, particularly in psychiatric illnesses. Depression and bipolar illnesses are also far and away the most common illnesses associated with suicide. Probably 70%, 80% of people who commit suicide had an underlying mood disorder of one kind or another. The mortality rate of untreated depression and bipolar illness is very high. Men and women are equally likely to get bipolar illness, but women are twice as likely, at least, to suffer from depression only. Bipolar illness is recurrent And if it's left untreated, it's progressive, which just means it'll occur more frequently, more rapidly, often more difficult to treat. Alcohol and drug abuse frequently accompany mood disorders, particularly bipolar illness. Again, 60% of people who have bipolar illness have a history of alcohol and or drug abuse. Nearly always, that substance abuse makes depression and mania much worse. Finally, and far and away most important, depression and bipolar illness are very treatable. Medication or psychotherapy or a combination of medication and psychotherapy effectively treat most individuals. It's very important to get treated early on in the illness. It's a lot easier to treat. And so just as a sort of a general statement of public health here and compassion, if you feel like you have any of the symptoms of depression or you aren't sure, get help. If you're concerned about one of your colleagues or friends, get help. As I say, it's really important that you do, and it's really important to get treated. I wrote a somewhat irate op-ed piece for the Washington Post one year because I was getting tired of all the people who kept quiet about having mental illness. Not that I strongly believe people have a right to privacy. Obviously, people should keep quiet for whatever reasons. Nobody has any obligation whatsoever to be public. But what happens when people keep quiet about depression, for example, or bipolar illness, is that all the public sees are all the people who are untreated or poorly treated. They're in the jails, they're on the streets, they're ineffective and troublesome colleagues. What people don't see are the millions of people who are treated very effectively, go out to work, compete, succeed. This is true whether you're in medicine or in the law. I live in Washington, or did until very recently. You wouldn't know from the city of Washington that there's actually a competent group of functioning people there, but they are, and quite a few of them are on medication. A few more of them perhaps could benefit. So let me just talk about, briefly from an Unquiet Mind, read a bit about my own experiences, what it feels like to be manic, what it feels like to be depressed, what it feels like to nearly die from a suicide attempt, what it feels like to fear that you're going to get sick again. And one of the reasons I wrote about Robert Lowell was he was somebody who's arguably certainly one of the preeminent poets in America in the 20th century, but he also was hospitalized 20 times for mania, and each time nearly destroyed his life, and he got back into the fray and competed. And what haunted him, I had access to his medical and psychiatric records, is every admission the doctor would say, Mr. Lowell is terrified of getting manic again, of getting sick again. Mr. Lowell is terrified. He feels so guilty and such remorse for the things that he did when he was manic. I think it's very hard for people. We all appreciate that if someone's had cancer, that they're going to be terrified that it will recur and wait for any evidence or signs that it might happen. I think what's very hard, unless you've had the experience of having been psychotic and having lost total trust in your mind, is how terrifying it is that will happen to you again. So I first had a major breakdown when I was in high school, my senior year of high school, when I was 17 years old. And up to that point, I had been, to the extent that one's perfectly normal, I'd been perfectly, I guess, normal. I mean, I certainly, relatively speaking, normal. And very involved in sports. I loved school. I had lots of friends, captain of my teams, all that kind of thing. I mean, there was no reason to expect that anything would go wrong. I came from a very WASP family. My father was an Air Force officer and a scientist and a pilot. Nobody talked about mental illness in that day and age. Not at all, nobody then, although my father, in fact, had the same illness I did, my sister does, lots of other people in my family do, but nobody talked about it. That was just not done. So when you are 17 years old and you haven't a clue, and there's not, at that time not much, public education about these things at all, so at least, it's terrifying beyond belief. So I got mildly manic, then I got suicidally depressed, and then I got well. And by the time I graduated from high school, I was perfectly fine to go off to college, up, down, all the way through my schooling. And then I joined the faculty at UCLA as an assistant professor in the Department of Psychiatry. And I went stark ravingly manic, hallucinations, delusions, the whole 9 yards. So my book, An Unquiet Mind, begins at that time. When it's 2 o'clock in the morning and you're manic, even the UCLA Medical Center has a certain appeal. The hospital, ordinarily a cold clotting of uninteresting buildings, became for me that fall morning many years ago a focus of my finely wired, exquisitely alert nervous system. With vibrosi twinging, antennae perked, eyes fast-forwarding and fly-faceted, I took in everything around me. I was on the run. Not just on the run, but fast and furious on the run, darting back and forth across a hospital parking lot, trying to use up a boundless, restless, manic energy. I was running fast, but slowly going mad. The man I was with, a colleague from the medical school, had stopped running an hour earlier and was, he said, impatiently, exhausted. This, to a saner mind, would not have been surprising. The usual distinctions between day and night had long since disappeared for the two of us, and the endless hours of scotch, brawlings, fallings about, and laughter had taken an obvious, if not yet quite final toll. We should have been sleeping or working, publishing, not perishing, reading journals, writing in charts, or drawing tedious scientific graphs that no one else would read. Suddenly, a police car pulled up. Even in my less than totally lucid state of mind, I could see that the officer had his hand on his gun as he got out of the car. "What in the hell are you doing running around the parking lot at this hour?" he asked. My few remaining islets of judgment reached out to one another and linked up long enough to conclude that this particular situation was going to be hard to explain. My colleague, fortunately, was thinking far better than I was and managed to reach down into some deeply intuitive part of his own and the world's collective unconscious and said, "We're both on the faculty in the psychiatry department." The policeman looked at us, smiled, went back to his squad car, and drove away. Being professors of psychiatry explained everything. Within a month of signing my appointment papers to become an assistant professor of psychiatry at UCLA, I was well on my way to madness. Within 3 months, I was manic beyond recognition and just beginning a long, costly personal war against a medication that I would, in a few years' time, be strongly encouraging others to take. My illness and my struggles against the drug that ultimately saved my life and restored my sanity had been years in the making. For as long as I can remember, I was frighteningly, although often wonderfully, beholden to moods. Intensely emotional as a child, mercurial as a young girl, first severely depressed as an adolescent, and then unrelentingly caught up in the cycles of mania and depression by the time I began my professional life. I became, both by necessity and intellectual inclination, a student of moods. It has been the only way I know to understand, indeed to accept, the illness I have. And it also has been the only way I know to try and make a difference in the lives of others who also suffer from mental illness. The disease it has on several occasions nearly killed me, does kill hundreds of thousands of people every year. Most are young, and most die unnecessarily. But my manias, at least in their early and mild forms, were absolutely intoxicating states. that gave rise to great personal pleasure, an incomparable flow of thoughts, and a ceaseless energy that allowed the translation of new ideas into papers and projects. Medication not only cut into these fast-flowing, high-flying times, they also brought with them intolerable side effects. It took me far too long to realize that lost years and relationships cannot be recovered. The damage done to oneself and others cannot always be put right again. And the freedom from the control imposed by medication loses its medication meaning when the only alternatives are death and insanity. But the war I waged against myself is not an uncommon one. The major clinical problem in treating bipolar illness is not that there are not effective medications. There are. It is, rather, that patients so often refuse to take them. Worse yet, because of a lack of information, poor medical advice, terrible stigma, or fear of personal and professional reprisals, they do not seek treatment at all. Bipolar disorder distorts moods and thoughts, incites dreadful behavior, destroys the basis of rational thought, and too often erodes the desire and will to live. It is an illness that is genetic in its origins, yet one that feels psychological in the experience of it. An illness that is unique in conferring some advantage and pleasure, yet one that brings in its wake almost unendurable suffering, and not infrequently, suicide. I am fortunate that I have not died from my illness. Fortunate in having received the best medical care available. Fortunate in being able to pay for that medical care, which most in this country cannot. And fortunate in having the friends, colleagues, and family that I do. Because of this, I have in turn tried as best I could to use my own experiences of the disease to inform my research, teaching, clinical practice, and advocacy work. I had many concerns about publicly discussing my mental illness. Clinicians have been, for obvious reasons of licensing, referral bases, and hospital privileges, reluctant to make their psychiatric problems known to others. These concerns are well warranted. I had no idea what the long-term effects of discussing such issues so openly would be on my personal and professional life. But whatever the consequences, they were bound to be better than continuing to be silent. I was tired of hiding, tired of misspent and knotted energies, tired of the hypocrisy, and tired of acting as though I had something to hide. One is what one is, and the dishonesty of hiding behind a degree or a title or any manner and collection of words is still exactly that, dishonest. Necessary, perhaps, but dishonest. I continue to have concerns about my decision to be public about my illness. But one of the advantages of having this illness for so many years is that very little in life seems to me insurmountably difficult. Much like crossing the Bay Bridge when there's a storm over the Chesapeake, one may be terrified to go forward, but there's no question of going back. I find myself taking a certain solace in Robert Lowell's essential question, yet why not say what happened? Writing and talking in a personal way about bipolar illness began for me with teaching. For years, I had been director of the Mood Disorders Clinic at UCLA, and it had soon become clear to me and to the other faculty teaching in the clinic that the psychiatry residents and clinical psychology interns were not on intimate terms with the subjective experience of mania, depression, or their treatments. Diagnosis, yes. Which drugs to prescribe, yes. But not what psychiatric illness actually felt like to those who had it. I wrote 2 brief passages several years ago now, and at the time, of course, anonymously, for the residents and other trainees in our clinic. I limited each of these passages to approximately 2 paragraphs, as I assumed that was about the limit of the residents' attention span. As you will know, a generous assumption. One was a general overview of bipolar illness, and the second, a description of some of the less than altogether delightful aspects of taking lithium. So the first is one patient, namely myself's, overview of bipolar illness. There's a particular kind of pain, elation, loneliness, and terror involved in this kind of madness. When you're high, it's tremendous. The ideas and feelings are fast and frequent like shooting stars, and you follow them until you find better and brighter ones. The right words and gestures are suddenly there, the power to captivate others, a felt certainty. There are interests found in uninteresting people. Feelings of ease, intensity, power, well-being, and euphoria pervade one's marrow. But somewhere this changes. The fast ideas are now far too fast, and there are far too many. Overwhelming confusion replaces clarity. Memory goes. Humor and absorption on friends' faces are replaced by fear and concern. Everything previously moving with the grain is now against. You are irritable, angry, frightened, uncontrollable, and enmeshed totally in the blackest caves of the mind. You never knew those caves were there. It will never end, for madness carves its own reality. It goes on, and finally there are only others' recollections of your behavior, your bizarre, frenetic, aimless behavior. For mania has at least some grace in obliterating memory. What then, after all the medications, the psychiatrist, the despair, the depression, the nearly lethal overdose? All those incredible feelings to sort through. Who is being too polite to say what? Who knows what? What did I do? Why? And most hauntingly, when will it happen again? Then, too, are the bitter reminders, medicine to take, resent, forget, take, resent, and forget, but always to take. Credit cards revoked, bounce checks to cover, explanations due at work, apologies to make, a ruined marriage. And always, when will it happen again? I wrote for the residents as well about the difficulties in taking medication, because many of the young doctors in our clinic found it incomprehensible and often infuriating that patients would stop taking drugs that so clearly worked against such devastating illnesses. I was treated in the very early days of lithium treatment, and I was treated at very high doses, kind of walk into the wall, slurred speech, end up in the emergency room for toxicity, vomiting in the National Gallery, kind of high-dose reactions. Things have changed. Medicine moves on. People are kept at much lower lithium levels now, and many fewer side effects. Lithium remains the gold standard of treatment. I owe my life to it, and I take it I take it every night, and almost every night without any kind of complaint. So this was what I wrote for not just the residents, but also for my doctor, who I have to say is an astonishingly good doctor. It's called Rules for the Gracious Acceptance of Lithium into Your Life. 1, clear out the medicine cabinet before guests arrive for dinner or new lovers stay the night. 2, remember to put the lithium back into the medicine cabinet the next day. 3, don't be too embarrassed by your lack of coordination or your inability to do well the sports you once loved and once did with such ease and pleasure. 4, nod intelligently and with conviction when your physician explains to you the many advantages of lithium in leveling out the chaos in your life. 5, be patient when waiting for this leveling off. Very patient. Reread the book of Job. Continue being patient. Contemplate the similarity between the phrases, being patient and being a patient. 6, try not to let the fact that you can't read without effort annoy you. Be philosophical. Even if you could read, you wouldn't remember most of it anyway. 7, accommodate to a certain lack of enthusiasm and bounce that you once had. Try not to think about all the wild nights you once had. Probably best not to have had those nights anyway. That's not true. I put that in for my husband. 8, always keep in perspective how much better you are. Everyone else certainly points it out often enough, and annoyingly enough, it's probably true. 9, be appreciative. Doctors love appreciation. Don't even consider stopping your lithium. 10, when you do stop your lithium, get manic, get depressed, expect to hear 2 basic themes from your family, friends, and healers. But you were doing so much better. I just don't understand it. I told you this would happen. 11, restock your medicine cabinet. Bipolar illness is complicated. As Frank says, it laces together loss with advantage and places despair in close proximity to great pleasure. There are very few things in life that do that, very few illnesses that do that. It is difficult to convey how powerful the allure of the early stages mild mania can be. But let me describe the beginning of one manic episode, which was a trip I took to Saturn unaccompanied by a spacecraft. I have to say, after Unquiet Mind was published, I got probably 10, 15,000 letters, and there was a whole subset of letters about people who had gone various places in the galaxy when they were manic, and which was better, and that Saturn, in fact, was just a really very dreary place to go when there are all these other alternatives. People go mad in idiosyncratic ways. Perhaps it was not surprising that as a pilot and meteorologist's daughter, I found myself in that glorious illusion of high summer days, gliding, flying, now and again lurching through cloud banks and ethers, past stars, and across fields of ice crystals. Even now I can see in my mind's rather peculiar eye an extraordinary shattering and shifting of light, inconstant but ravishing colors laid out across miles of circling rings, and the almost imperceptible, somehow surprisingly pallid moons of this Catherine wheel of a planet. I saw and experienced that which had been only dreams or fitful fragments of aspiration. Was it real? Well, of course not in any meaningful sense of the word real, but did it stay with me? Absolutely. Long after my psychosis cleared and the medications took hold, it became a part of what one remembers forever, surrounded by an almost Proustian melancholy. Long since that extended voyage of my mind and soul, Saturn and its icy rings took on a private beauty to me. And I don't see Saturn's image now without feeling an acute sadness at its being so far away from me, so unobtainable in so many ways. The intensity, glory, and absolute assuredness of my mind's flight made it very difficult for me to believe, once I was better, that the illness was one I should willingly give up. Even though I was a clinician and read the research literature, and indeed wrote some of it, and I knew the inevitable bleak consequences of not taking lithium, I, for many years after my initial diagnosis, was reluctant to take my medications as prescribed. Why was I so unwilling? Why did it take having to go through more episodes of mania, followed by long suicidal depressions, before I would take lithium in a medically sensible way? Certainly there were real and unpleasant, not to say disruptive, side effects. Some of my reluctance, no doubt, stemmed from a fundamental denial that what I had was a real disease. This is a common reaction that follows, rather counterintuitively, in the wake of early episodes of bipolar illness. Moods are such an essential part of the substance of life and of one's notions of oneself that even psychotic extremes in mood and behavior somehow can be seen as temporary, even understandable reactions to what life has dealt. In my case, I had a horrible sense of loss for who I had been and where I had been. It was difficult to give up the high flights of mind and mood, even though the depressions that followed nearly cost me my life. I reaped a bitter harvest from this refusal to take lithium on a consistent basis. A floridly psychotic mania was followed inevitably by a long and lacerating suicidal depression. It lasted more than a year and a half. From the time I woke up in the morning until the time I went to bed at night, I was miserable and incapable of any kind of joy or enthusiasm. Everything, every thought, word, movement was an effort. Everything that once was sparkling now was flat. I seemed to myself to be dull, boring, inadequate, thick-brained, unlit, unresponsive, chill-skinned, bloodless, and sparrow drab. What is the point in going on like this, I would ask myself. Over and over, I would say to myself, if I can't feel, if I can't love, if I can't move, if I can't think, and if I can't care, then what conceivable point is there in living? I reasoned they would kill an animal who was in far less pain. I could not bear the person I had become, and could bear even less the burden I felt I had become to those who loved me. My psychiatrist repeatedly tried to persuade me to go into a psychiatric hospital, but I refused. I was horrified at the idea of being locked up, being away from my friends and familiar surroundings, and having to put up with all the indignities and invasions of privacy that I knew went into being on a psychiatric ward. I was working on a locked ward at the time, and I didn't relish the idea of not having the key. Mostly, however, I was concerned that if it became public knowledge that I had been hospitalized, my clinical work and privileges at best would be suspended. At worst, they would be revoked on a permanent basis, and I would be fired. At the time, nothing seemed to be working, despite excellent medical care, and I simply wanted to die and be done with it. I resolved to kill myself. I was cold-bloodedly determined not to give any indication of my plans or the state of my mind, and in this I was successful. The only note made by my psychiatrist on the day before I attempted suicide was severely depressed, very quiet. I took what I knew to be a greater than lethal dose of lithium. I was a lithium researcher. And I took an antiemetic to keep from vomiting the pills. I was in and out of a coma for several days and nearly died. As a result, I no longer fight taking lithium. Repeated psychosis and a nearly lethal suicide attempt have a way of convincing even the slowest of learners. And I am fortunate to have been able to take some of my own experiences into my teaching and writing. I'm also enormously fortunate to have had the support of the chairman of my department when I was at UCLA, and for many, many years now, the chairman of psychiatry and the president at Johns Hopkins and the president of the Johns Hopkins Hospital. When I was a young assistant professor at UCLA, and I might add there were 80 professors in adult psychiatry, and I was the only woman, all the women clustered in child psychiatry. So I was a woman, I was a non-physician, and I was psychotic running a clinic. I can't begin to tell you how many people were just kind of annoyed by that, my chairman stuck by me. And he said, look, I understand you have a problem with your moods. And I said, well, that's one way of putting it. And he said, just keep seeing your doctor, keep taking your medication. And he said, learn from it, teach from it, write from it. He never once suggested that I go into, quote, less stressful line of work. He never once suggested I quit. He just, from time to say, would say to me, learn from it, teach from it, write from it. When I went to the chairman of my department at Johns Hopkins to say, look, I've written this book, it was a manuscript, and I don't want to do anything that's going to put Hopkins in a legal problem, difficulty, PR. There are a lot of legal issues, a lot of ethical issues, a lot of teaching issues. you can only imagine. And I said, but I do think it's important for professionals when they're in a position to be able to do something public, to do it, because then people at least know there are people out there who are doing it okay. And he said, stop. He said, you've got it exactly backwards. He said, when Professor Halstead was here, Professor Halstead was the first professor of surgery at Johns Hopkins and one of the great American surgeons yet. And he said, there were people on the faculty who knew that Professor Halstead was a cocaine addict and a morphine addict. And they took it upon themselves to do a couple things. First was to protect Professor Halstead's patients from Professor Halstead when he was sick. The second was to protect and help Professor Halstead so that he could continue to teach and train young surgeons. He said, if Hopkins can't do that for you, Hopkins has no business being in business. This is exactly what we should be doing. He lined up a luncheon for me with the president of Johns Hopkins Hospital, who said exactly the same thing. We have your back. If anybody gives you any trouble, from the house staff, faculty, anybody, we want to hear about it, and we want to do something about it. And, so I'm not so naive as to think that this is usual. I've been to too many medical schools and hospitals to know that it's not usual, but it is exemplary. And it's from the exemplary that one learns, not from things done badly. And I speak here today because of their compassion. Thank you. I deliberately left a lot of time for questions, so feel free. I can't think, well, I'm sure I could think of questions that would be offensive, but that would be hard. I'm open to any questions, clinical, personal.
Hi, how has the meds affected your creativity and just the whole creative process?
The question is how medication affected my creativity. One hesitates to call oneself creative. I mean, I would say that nobody's creative who's in a hospital ward or in 4-point restraints or 6 feet under, and I believe that very, very strongly. I believe this is a destructive disease. I believe that mania has huge attractions, and it's very important to understanding a lot of things about human history and imagination and so forth, but it's ultimately a very destructive disease. I would be dead. So, I mean, there's no question. I have a lethal form of this, and I have a very bad psychotic form of mania. Neither of those are great predictors of being successful in life. I don't feel when I was on a high dose of lithium, I couldn't read, which is, if you're trying to get tenure, in some ways it had the advantage of I certainly bypassed a lot of very boring reading, but professional reading. But, I mean, it puts you at a certain disadvantage. And, I would have to mark things through with yellow marker and underline and write out the entire abstract of an article and so forth. And even then, only a bit of it would drift through. So it was hard. And so when I went to a lower lithium level, everything changed. And I think, all of my books have been since I have been on lithium. So it's hard for me to know. Nobody knows what would happen if they had done something else. But I would say that the evidence is very clear that this is an illness that damages the brain at a structural and functional level, that if you have a brain scan of somebody on one manic episode versus 8, you want the brain with one episode. And that lithium has kept me alive. Lithium has a very good track record for preventing suicide. So I don't have the luxury in a way. I just know I would be dead. So, unless people are creating a lot of things in the grave we don't know about. But I think it's a really legitimate question, and it's a question that comes up from artists and writers all the time. And I think what you want to be able to say to people is, it's complicated. These drugs do act on the brain in a very definite sort of way, and they affect a lot of the systems that are also involved in creativity. The two not so good studies, but there are only two studies actually asking artists and writers whether they felt as productive, more productive, or less productive on lithium. And 3/4 of them said as productive or more productive. And that's just because a lot of them were sick for long periods of time. But it's a complicated question. I think in this day and age, it's something that doesn't have to be either or. I think that people can figure out ways of combining psychotherapy with medication, and learning about the illness and how to ride maybe some highs along the way and charting their moods. I think there are a lot of things people can do that they didn't used to be able to do. So I'm much more buffo on this than I used to be.
We're hearing now of some children being diagnosed with bipolar at a very young age. And I was wondering if you could talk about the ethics and ability of people to diagnose at a young age.
Right. The question is, what about early onset or pediatric bipolar disorder? And what about the ethics? I wouldn't put the word ethics in unless somebody is doing something that they're getting payment for, or they are just so completely negligent. What I would say is that there are a lot of people who, for quite a while after bipolar illness became much more talked about in adult populations and adolescent populations, started applying it to kids who had dubious diagnoses. It's much harder to diagnose bipolar illness in children, okay? So if you've got an adolescent, that adolescence, the clinical presentation of adolescent bipolar illness is going to be very like the adult, and the course of the illness, treatment response, and so forth. In children, it's much harder. People can have wild temper tantrums. They can do all sorts of things, have attention deficit disorder, and people can say that's bipolar disorder. I think what we have learned over the last 10 or 15 years is be a lot more careful. Don't overdiagnose it. Don't think you know more than you do. If you have doubts, refer to a second opinion of somebody who's a specialist in this. We know that certain symptoms in childhood that are quite characteristic of adult mania are much more likely to be associated with true bipolar illness in children than in adults, than non-bipolar children. So we know the family history is a genetic illness. We know you can get information from a lot of things to make an informed diagnosis, but it's also true that this is a place where you really want science, and you want to be able to do the kinds of studies in this right now, so that 10 years from now you can just do a blood test or a scan and find out if the child has bipolar illness, and not put that person on unnecessary medications, and for sure put them on medication if they need it.
So my question is about the medication lamotrigine.
Oh.
It's worked for me for over 10 years with bipolar disorder, and I understand that it's very commonly prescribed and quite successful. I was wondering, in your experience being in the field for decades, and lithium being prescribed so much longer in history, what your opinion is on lamotrigine in particular, since my understanding is that it's
Lamotrigine?
prescribed a lot, and then also any innovations and medications that you see that you feel positive about.
Right. I think one of the things that's true, whatever branch of medicine you're talking about, is that people have individual responses. So some people don't respond at all to lithium. Some people can't tolerate lithium. Some people won't take lithium. So there's a group that's a real problem. Some people respond very well to lamotrigine. particularly people who don't have severe manias. I mean, we know that it's better treating the depressive end of the continuum than preventing manic episodes. So the question, I mean, in the whole class of drugs, the anticonvulsant medications have been a source of a lot of research, a lot of theoretical discussions about what might be going on in the brain that causes the bipolar brain to respond to anticonvulsant medications. I think what's safe to say, what's coming down the pike in the short term, not a whole lot. I mean, the drugs all look kind of like variations on a theme. It's very expensive to develop a drug. There's some drugs like ketamine that are being used for acute suicidal patients, and I think the jury's out on that, but there's certainly, each time something like that happens, people learn a lot from the science of studying what it is about a particular drug that works or doesn't work. I think we're doing a lot of work in neuroimaging, understanding what parts of the brain are affected, how it's affected over time, how some of the damage might be reversed by some of the medications. So that's a very promising line of research. Probably if you had to put money down somewhere, it would be in genetics because, I mean, as we speak, there are huge studies being done, particularly at the Broad Institute. MIT and Harvard have a joint genetics effort on bipolar genetics, and they're finding some really interesting things. So if you're going to talk about you want an early diagnosis for childhood, you want an early diagnosis, you want a correct diagnosis, you want to have medications that are specifically geared toward the particular form of a disorder that the person has, that's where probably the ultimate money is going to be coming. Is it going as fast as anybody would like? No, but it's going okay. It's an exciting field.
For families who have a strong genetic history, what advice do you have to parents on ways to be proactive in how and when to talk to children, so you can hopefully not have to have them go through a whole bunch of episodes before we get treatment?
Right. The question is, what can you do if you know you have this illness in your family? How can you help educate and perhaps mitigate some of this? You start one place which is always kind of interesting to me. I spend a lot of time on college campuses because of the age of onset, this illness. And I'm amazed by how many kids found out only after they were in the hospital that they had this illness in their family. So the parents had not sat down with the kids and said, look, we've got this illness. It's a treatable illness. The odds are overwhelming that you won't get it because that's true. Even if both parents have it, but certainly if one parent has it, so the odds are you aren't going to get it. But if you do, these are the signs and symptoms. I want you to call me. If you don't want to call me, you do your homework in advance. People go out and look at gyms. They look at these wellness centers. They look at everything on campuses. What they don't check out is the medical facilities. And there's a lot of not so great medicine practiced on college campuses. So I think that, parents minimally can go out and find out who are the specialists. Go to the nearest university hospital or medical school and go to the chairman's department, phone and say, who are the people who are the specialists? This is the illness that runs in my family. And who are the people out in the community who are practicing who do that? So that's sort of a minimal thing that people don't tend to do. Another is just talk about it very frankly, just not obsess about it, but say that this is how it tends to look early on. Again, you're unlikely to get it, but if you do, there's a lot that can be done. What you really don't want to do is ignore it. So I think there are a lot of things you can give people. The nice thing about adolescence is kids tend to read. They really do, and they tend to talk about these things. So, I went to Oxford a couple of years ago, and one of my colleagues here said, the kids aren't going to have any questions. They're too shy to ask about this. I said, trust me, it'll be your colleagues who won't ask, And the kids will have plenty of questions, which is absolutely true. I mean, there's no shortage. I mean, for one thing, the internet makes things, obviously, the good thing about the internet is it's available, you can get good information. The bad thing about it is, some of the information is so incredibly off the wall, so it's hard to stomach. But, there's a lot of stuff out there. There are a lot of programs at colleges now to try and make kids more aware. There are all sorts of barriers, in a funny sort of way, legal barriers to telling parents, breaking confidentiality and all that sort of thing. So one of the things that you can try and talk about with your kid is, do you mind if we sit down and draw up an agreement with the college or the university that says, if there's something very serious going on with you, that they will call me, because that doesn't go on now.
I want to express again what I suspect you've heard many times, but our collective appreciation for your courage and candor. And I'd like to ask you, if you would, to go back to a comment you made early on in your discussion, where you just surfaced the issue of what it's like to live a life wondering if it's going to come back. If you wouldn't mind, can you just tell us how you deal with that?
Yeah, the question is, how does one live with a potentially recurrent illness? Well, I think early on in the illness, you simply haven't a clue, and you're not as stabilized, because it takes several years to stabilize. So you're going to have more breakthrough episodes. So that's enough to scare you right there, okay? So, just the reality. I think after you've been on medication for a while and you've got sort of sorted out doses and right medications and all that kind of thing, it should be an issue always, I think. I think one should always have it in the back of your mind. Not to get paralyzed by it or incapacitated with terror, but to just say, it's realistic. What if I couldn't take lithium tomorrow? I had some disease that didn't allow me to take lithium. I'm up the creek, okay? That's real. I want to be doing some planning and thinking about that in advance. I'm hopeful that won't be true. It doesn't tend to happen very often. But, there are all sorts of contingencies. Or I could just I could need to be on steroids for some medical condition and just blow myself into a mania, unless, there are all sorts of, believe me, I've thought of them, of many of the possibilities. And I think, to me, I guess I don't think life is certain. I think one of the great pleasures and horrors of life is that it's uncertain. I'm pretty comfortable with uncertainty in a way. I think that's just, I think I'm very lucky to respond to lithium. I think I'm very lucky to have had the medical care that I've had, do have. I think one thing you can do, and I encourage people, and I encourage the residents to encourage patients to do, is to have a living will, in effect, directives, advanced directives. So I have an advanced directives that says, if I get manic again, or if I get depressed again, suicidally depressed, my husband can do whatever he sees fit. If he thinks I need to be in he's a doctor, but even if he weren't a doctor, if he thinks I need to be in the hospital and I need to be taken in by the police, fair enough. Likewise, if he thinks that about my being suicidal. I also have on there the drugs I don't want to be given. I have on there that if I get seriously suicidally depressed again, I want to have ECT, electric shock, because I think that's what would be appropriate for the kind of illness I've got. So, I want to be hospitalized on Meyer 4 at Johns Hopkins. It's a pretty specific list. But I think that what that does is it says when you're at the top of your game, when you're thinking rationally, you make decisions that you're not going to be making when you're irrational. And some states this is legal, some states it's not binding. My feeling is it gives moral authority to my husband and my doctor. It says, this is what I want. I mean, I have no doubt they would do it anyway, frankly. That's why I like them, is I trust them, is they would do it. But it gives them the authority to know that that is my wish. So, because if you have to commit somebody against their will when they're manic, it's a really hard thing to do. It breaks families apart, and it breaks people up inside. And I don't want to put somebody through that. So you plan for, I hope for the best, that I'm not going to get sick again. And working around a psychiatric ward, you don't have guarantees.
I just wanted to start off by saying thank you. For having this here in session. I think our community here in Denver is very similar to that in Baltimore, very, very diverse. And the agency that I work for, we work with a lot of refugees and immigrants and asylum seekers. So you were talking earlier about appropriateness with clinical diagnosis, and so I'm just curious if you've seen any cultural nuances in clinical presentation or symptoms, and if you could kind of speak to that for us.
Well, certainly, I would say historically more of a cultural, ethnic difference in how people were diagnosed. I mean, if you take it way back in the early part of the 20th century, there's studies that show that the more affluent you were, the more likely you were to be diagnosed as having manic depressive psychosis rather than schizophrenia, because you were giving somebody a relatively better prognosis. And then there are a lot of studies showing for quite a while that African Americans, if they had the same clinical presentation of hallucinations, delusions, and so forth, were much more likely to be diagnosed as having schizophrenia than bipolar illness. I think that has gone way down. I think the diagnostic practices are much more uniform now than they used to be. It's not to say that there aren't pockets of awfulness and mistakes, but I think it's changed a lot for the better. But I mean, I think the real inequity, if you're talking culturally, is, it's healthcare, right? I mean, for those of us, who've been advocating for 30 years, and we finally get a president who signs into law healthcare so that people with long-term psychiatric illnesses can get treatment. And who talks publicly about depression and bipolar illness and mental illnesses and so forth, we're just watching it unravel, right? So from my point of view, it doesn't do any good for people to get all the opinions they want or better diagnoses, better treatments, if they can't afford care. And that, in this country, unlike any country that I know of in Western Europe, we just let people die from their psychiatric illnesses and suffer, kill themselves. So that to me is the discrepancy. So, I'm living in Baltimore, the community, there's no pretense of equity there.
Thank you for bringing that social justice piece to our attention. I wanted to also ask you if you could speak to the psychotherapy part of treatment of bipolar disorder.
Sure. I think, increasingly over the last many years, people have studied that to see whether I don't think anyone has seriously tried to say not medicate people, but the question is, if you have people in psychotherapy as well as being medicated, A, are they more likely to continue taking their medications, and B, is their long-term adjustment and health better? And I think the answer is yes. It's not resoundingly yes, but it's yes. But people have begun to study it in a very systematic way. So I think that, and the therapies vary enormously, of course, from very practical therapies that say, watch your sleep, which is probably the single easiest way to get manic, is to lose sleep, so to really enforce that notion in people. The importance of daily life and all that kind of thing, to in-depth psychotherapy, kind of dynamic psychotherapy. I think from my point of view, I speak a lot that, in my teaching to residents and medical students is that, I have no doubt that psychotherapy saved my life. I mean, lithium keeps me alive, kept me alive, but the fact that I had a deeply humane doctor who didn't sort the world into psychotherapy over here and medication over here, he was just really good at both, and understood, kind of what made me tick, that I was extremely lucky, and if I hadn't had that, I have no doubt that I would not be alive. So psychotherapy makes a lot of difference to an awful lot of people. It's a little bit harder to study than medication trials, but people have been doing it.
First, I want to thank you for your time on a Friday afternoon here. I have two questions that are similar, related to the stigma that comes from healthcare workers. You mentioned towards your end of your discussion with the higher-ups at Johns Hopkins about them wanting to know if you ever received any negative feedback about sort of coming out or publishing your book, and if they had any stigma towards you for your mental illness. I wonder if you can reflect on that. And if there are any general tips or advice you have for folks working in non-psychiatry healthcare places that they may work with people that have negative stigma towards healthcare, towards mentally ill patients. I work in a non-psychiatric inpatient unit, and oftentimes we hear people say, "Oh, that patient's just crazy," or "They're psychotic," or "They're just an alcoholic." Like, how would you go about approaching those people in the heat of the moment to help correct that stigma slowly but surely?
Well, it's very interesting because before I went public, I had been working on psychiatric wards for years and working and directing a clinic with a lot of people with mania and so forth. So I heard a lot of jokes, I heard a lot of comments, a lot of pretty awful statements. And I decided at some point, if I couldn't tolerate that, I couldn't tolerate it and I shouldn't be doing it. And that, there's an aspect of, I think, that is legitimate in saying awful things, which is that people, when they get together and they're under stress, vent, and they say things that they would not otherwise say. Okay, so that I'll just sort of say that, and I believe that that's true. And I think if you get too undone about those things, you're going to have trouble in life because, things are just at times difficult. But the question is, when I came out, I would say my colleagues at Hopkins could not have been more wonderful, except one colleague gave me a very bad time, but the rest of my colleagues were just fabulous, and they continued to be fabulous and continued to be very supportive. For the most part, my colleagues in medicine and surgery and psychiatry, great. I would say some colleagues, researchers, funnily enough, said basically you should keep your mouth shut, do research, and, the world doesn't need to know about all this stuff, basically, which is helpful, since I already said it. But, I think I got as much support. I mean, there are people who criticize anything, it's just, you look at letters, and I got letters just talking to people at lunch, you get threats. There are a whole lot of people who really, really believe that you are the devil's work if you have been psychotic. Amazing number of people. I had no idea the number of people who said basically, drop dead, you're evil now, blah, blah, blah. It's a good thing you didn't have kids, just on and on and on. So that was not great. A lot of people were very supportive, and some people were jerks. So that's sort of, I think I knew when I went out that things would be difficult. I had no idea how difficult they would be. I didn't have any idea how many really unglued people there are out there that make you feel really threatened. But I also had no idea how wonderful most people could be. And one of the great privileges of writing this book is that to be able to go so many places across America and in Europe and hear people's stories and hear what they go through and hear, the suffering in families. And I ended up writing a book about suicide. I had no desire to write a book about suicide. I had no desire to read day in and day out for a couple of years about suicide. I'd been already close to the bone on that one. But I went to so many book readings, and people would come up and show me pictures of their 15-year-old kid or their 20-year-old kid who was dead, or send me autopsy reports and so on. And it just broke my heart in two. And what I realized is that, this is an incredible, huge percentage of the population hurting out there, and yet wit and wherewithal and gumption and giving back to the community. So that part of it I wouldn't trade for anything. I felt very, very lucky in that respect.
Thank you for your courage. My question is, what's the prognosis for people with bipolar illness who develop Alzheimer's?
Interesting question. Question is, what are your odds of getting Alzheimer's if you have bipolar illness? There's several papers. I'll address it somewhat indirectly because I don't think we really know. These are not great epidemiologic papers, but what we do have is a series of papers now that trace people who have bipolar illness, who were treated with lithium and who were not treated with lithium. And the people who were treated with lithium, their dementia, all dementias, I mean, not so much differentiating Alzheimer's, but all dementias is population rate or slightly lower. If they're not treated with lithium, it's way above the population rate. So the old notion of people, in the 19th century, people would end up in the asylums, demented, and it was hard to tell whether it was chronic mania, which a lot of people were in asylums for, and how much of that just progressed to being true dementias. But we know that the rate of dementia is higher in bipolar illness, and we know that lithium brings it down.
Thank you. Your talk is very insightful. My name is Julia, and I'm a citizen, new here in Denver. I come from a family that's at least 5 generations of bipolar, manic, depressive. And I wanted to thank you for also putting a lens on, I think it's really important what you said about having the people who are leading healthy, happy lives with this condition out there, because I don't know about anybody else, but I still feel like there is a stigma. I personally have PTSD, and I know that when I'm applying for a job, I hesitate to put that down. I manage it. But I was curious, when you're having or feeling like you're going to have an episode, is there something that triggers it, or does it just come naturally? Like, I know for me, there is something that's triggering me. I'm very aware of it now. I wasn't before I was diagnosed. So that was one thing. And then the other is my sister and my niece have had serious bipolar, manic depressive, major suicidal attempts, over like 10 each. So they stick out in the family. But the rest of the family, there are many of my brothers and sisters, aunts, uncles, cousins who actually do have this, but they don't seem to want to come forward or know about it. So how would you suggest, like you said, being clear and just being sober about the whole thing? I mean, should I say something, or how do I even just talk to my own family, put it that way?
Well, the first question was about...
Thank you for all those listening to all that.
The first question was about are the things that can trigger it. With PTSD, that's more, I think, more obviously an immediate precipitant. The evidence in bipolar illness is that perhaps the very first episode of mania is more likely to be precipitated by something in the environment, by stress, but then the illness takes on a life of its own. Now, when I say stress, though, that can also mean people miss sleep. So one of the things that happens in college campuses, if you wanted to take a cauldron of risk, you would say, okay, you would take somebody who's at age of risk going off to college, so 18 or so, you would have them do the two things that are most associated with triggering the first episode of mania. One is sleep deprivation, so people just kind of completely invert their sleep cycles and stay up at, nights in a row. And the other is to start using alcohol and drugs, which also affects the sleep cycle. So those are the triggers that are probably most clearly related to the very early episodes of mania. And then often in people's lives, they may, when I was at UCLA, for example, we had a whole bipolar group therapy, and they were all litigators, all lawyers. And what many of them would do was before a trial, they would start staying up all night, preparing for a trial. They'd be really good on their feet, really clever, really articulate, and then go completely, around the bend. So sleep is one of those things that is a trigger, sleep deprivation. The other about, who tells what in the family, I think it's really hard to say. I think that, talking to a couple other members of the family about, what you hope to gain by doing it. Is it realistic to do it? What's the downside, or write it. I mean, I'm a great advocate of people writing things. If they don't feel comfortable saying things, to write them, because you can then articulate perhaps a little bit more clearly what it is you really feel. But it's a very hard situation.
So I'm bipolar on this side again. And again, it's an opportunity to have access to this. Thank you so much. So not to diminish the hard work, navigating life with these illnesses, but what are some of the things that either you've done or the research shows are helpful, are protective factors, are things that maybe we didn't do so much when we were so focused on medication that we encourage people to do now?
I would say in some ways, some of the things that I did that I really enjoyed probably didn't help my illness. I think that's a very real point. And one of the things, when I wrote about Robert Lowell, I was interested in how on earth did someone who had such a devastating disease get up in the morning. So he would go teach, he taught at Harvard, and he would go stark ravingly manic almost the end of the fall term. He would, kind of almost leap out of the window. He would start being abusive and manic and so forth. Police would have to come and take him away. Totally humiliating, right? So the questions that come up from students is, how did the students handle this? It was really hard for them. Absolutely true. My question is also, how did Robert Lowell walk back into that classroom? Okay? What went into that? And I would say immense character, immense learning from people he admired, a sense of heroes in life that he went to draw upon consciously how they survived. Everybody from Achilles to colleagues, to poets, to great statesmen, to military officers. How did they survive ordeal? Now, I think in this day and age, and Frank and I were just talking about that not long ago, I think in this day and age, the notion of heroes is a rather quaint one. Who gets caught up in the idea of a hero? But these are very real people. They were to the Greeks, they were to the Romans, and they were to everybody across time as exemplars. Okay, so I think Lowell not only got personal courage with which to face the day, to apologize over and over again, to put back his marriages over and over again, put back his colleagues and students all over again, and remain deeply loved man, which was amazing. But he loved it. I mean, he loved history. And I think that, I often ask students, what is it that you love? What do you really love, And, I think history, reading, walking, dogs. I mean, people love different things, but it's a question of focusing on that and bringing it up into the consciousness, I think. I don't think we think consciously about heroes anymore or about exemplars. I know when I first got sick, I was sitting there in my office, my very small office at UCLA, and I had read three memoirs, but two memoirs that I wrote to. One was by Josh Logan, the playwright, South Pacific and Sayonara and all sorts of great plays. And he had written a book about his manias and depressions and being psychotic and how humiliating it was and so forth. And a man named Sloan Wilson, who wrote A Summer Place and The Man in the Gray Flannel Suit. Both of them had written books about their experiences. I had no one to talk to. I didn't know anybody. Well, I'm sure I knew people, but I didn't know anybody that I knew had the illness I had. I couldn't talk to any of my colleagues. So I was really isolated. And I wrote to both of these people, and they both wrote back, amazingly enough. And particularly Sloan Wilson, I corresponded for years, and I said, how do I survive this, And he said, it's hard. You start from the premise, it's hard. And that's what I always tell students, start from the premise, it's hard. You can do it, you can gain from it, you can draw upon it for the rest of your life. But it's hard. And if it's not hard, you probably don't have this illness. So.
Hi, over here. So I just wanted to tell you that you're a huge inspiration to me, and I felt really honored to be in your presence today. And I actually nominated you to be our commencement speaker for my class of 2021, my medical school class. So this is a great opportunity. I'm so glad you're here.
Once of me is enough.
So I just wanted to ask you a question about what you think about bipolar disorder, and if it's possible that it could actually be cured in a person. I was diagnosed with bipolar disorder when I was 20, and when I was 27, I was undiagnosed. So I was taking lithium for years, and then I suddenly didn't need it anymore. So I was wondering your thoughts on that.
If you look at, there are different ways of looking at the data. Some of the clearest lines of evidence are from the European studies, longitudinal studies, before treatment was available, because treatment can both give you a misleadingly optimistic notion of the course of the illness, and in this day and age, antidepressants can give you a misleadingly bad notion because in a lot of people it may trigger mania. So the pre-modern treatment European studies show a pretty consistent thing. If you have one manic episode, the consensus is, a consensus literally in a medical consensus conference sort of sense, the consensus is you've got the illness, okay? So, are there individual exceptions? Almost certainly. There's an individual exception. Everything, if we don't know anything about bipolar illness other than the fact that it's a collection of disorders rather than a single disorder, there are many different manifestations. By and large, if you've had a full-blown manic episode, it's there. Likewise, if you've had more arbitrarily with depression, if you've had 2 or more episodes of major depression, the assumption is you're probably going to have to stay on medications longer. Again, individual differences, but by and large, it doesn't go away. If you've got bipolar 1 illness, it doesn't go away.
I'm pharmacy students, and a lot of what we do is patient education to increase adherence. So I want to know if there's anything you might suggest that we should incorporate in our discussions to maybe increase the likelihood of patient takes these medications.
Yes. I mean, the 2 most naughty clinical questions with bipolar illness are getting people into treatment and keeping them on medication. It's very hard. It's particularly very hard in young people. The non-adherence rate is about 50% in bipolar. On the other hand, as my husband says, who's a cardiologist at Hopkins, you and your colleagues in psychiatry go blathering on about non-adherence. You try being a cardiologist. People smoke, they drink, they don't exercise, they don't take their statins, enough already. And I do think that that's true. I think the major problem in medicine, really, is once somebody's diagnosed with a treatment that works, is how to keep them on it. So it's a not terribly sexy research question, but it's an enormously important public health question and medical question. I think sometimes educating people helps some. Sometimes I think that's one of the goals of psychotherapy, is to try and increase that. But it's just very hard. And titrating medications, of saying, look, we're in this together. One of the things that people can do, one of my colleagues at Hopkins, Adam Kaplan, for example, uses mobile phones to call in moods, is to have a much more collaborative interaction with the patient and say, look, track your moods for 6 months, for a year. We'll find seasonal patterns. We'll find premenstrual patterns. We'll find patterns showing that you do respond to the medication, you're getting worse on the medication, there's no effect of the medication. But start off with a collaborative sort of thing so people often feel cornered. They feel like they're rats in a corner. Somebody's just trying to get something down their gullet. And if you say, look, this is really important, I want to give you all the information I can, all the science that we have, and it's important for you to know what the consequences are of not taking the medication, but we're also going to do everything possible to have your medication lower so you don't have the side effects, to do all the different things. So I think it's to the extent that you could make it a collaborative effort, and overtly so, it sometimes helps. But it is a big issue. I have a slide that I use in teaching that shows, I lived in Washington, first of all, the Pentagon got bombed, and then we had some sniper that was taking people out randomly in Washington. So the whole city was like this. And then we got anthrax, right? So somebody was just mailing in anthrax. And so under those circumstances, the public health people moved in beautifully, gave everybody free medication, Cipro, and, for a 3-week trial, to just take this so that they wouldn't die if they got exposed to anthrax. So it was free, no stigma, relatively few side effects, drug, public behind them. Under those circumstances, in the city of Washington, 60% of people took the Cipro, okay? So this is a 3-week trial. This is not, you're not putting somebody on medication, telling some 18-year-old that you're going to be on lithium for life. There's something about people that really resists that.
Thank you for your words today. Over here.
Oh,
hello.
Okay.
I was wondering what you could share about late onset, later adulthood, bipolar illness.
Sure. The question about late onset, with late onset, you have more issues. That it could be, there are a lot of things that can look like mania. So if somebody's presenting and they look like they're manic, It could be due to vascular things. It can be due to any number of issues that you wouldn't expect, perhaps in somebody younger. People who have later onset mania generally don't have the kind of family history, personal history. So if somebody presents without a personal history of depression or mania, without a family history of depression or mania, and they present at the age of 50, you got to start thinking about, is this really bipolar illness or not? And if they do have it, I mean, if they have it because they've had it all along, then there's certain issues that come up in terms of, medications and doses of medications and so forth that wouldn't be that different from any other geriatric way of looking at it. But there are an awful lot of things that can present as mania, and depression.
Thank you so much for the presentation. I'm curious, when you first experienced the symptoms of adolescence and as you're progressing into early adulthood and experiencing manic symptoms, what level of support do you think that you needed or you wish that you had?
I didn't have any support in the sense of somebody supporting, quote, an illness, because I didn't see a psychiatrist until I was 27. Okay, so I had been ill for 10 years, off and on. But it wasn't conceptualized as an illness, so nobody was providing those kinds of supports, as it were. I think I was lucky that I had a lot of really wonderful friends. And a very wonderful family, a little squirrely, but quite wonderful. I think that I had the advantage, perhaps, of I had a lot of things I loved doing, and that when I was normal, I was pretty normal. So it was more after I got overtly manic, psychotically manic, that people were supportive or not. And I would say in my family, my father, who's the one who has the illness as well, and my sister were the ones who were least supportive and were adamant about my not taking lithium. They thought it was a crutch. They just thought, on and on. My brother and mother, who are, really normal people, were enormously supportive. Went in to see my doctor with me. My brother always said to me, I will be on the next plane, if you need me. So I couldn't have asked for more support from them. It was pretty undermining. One of the nice things about An Unquiet Mind is when I passed it around to my family, because I said, this is not mommy dearest here. I love my family. I'm not interested in, saying things that are going to be difficult for you all. And I gave it to my father thinking he would be, because I had made it pretty clear that he was a little out there, and he said, good for you to do this. And he said, sweetheart, he said, I think I may have this illness. And I said, well, it's been suggested, Dad. And he went on and started taking lithium, and he was, until the day he died at 95, he was a crusader rabbit for lithium. So, but he wasn't very supportive to begin with.
Hi there. I'm also representing the School of Pharmacy here. And my question's pharmacy related, but it comes from personal experience. Bipolar disorder has an interesting way of letting you see the darkest things and things that are beautiful, but also seeing the most beautiful things and things that are dark. And people tend to hold on to that feeling that they have in a hypomanic state where everything's great and you can accomplish everything you want and you feel perfect before you crash. When you have somebody who is refusing medication and has started medications but stops and isn't compliant, and even though you think that they have hit rock bottom but they haven't, how do you get these patients to realize that although they're feeling fine now, this is going to happen again, and it's going to keep happening if you don't get the help that you need?
I mean, simply put, it's really hard. It's not, if people are hypomanic and they're feeling great, you cannot tell them they are not feeling great and that they're ill. Okay, it just doesn't, you can, it's not going to work. And you lose any ounce of credibility as a clinician for being observant or understanding the illness. What you have to say is put it in the context of the overall disaster. And sometimes you can do that and sometimes you can't. Sometimes if you're trying to deal with an individual who is, say, escalating into mania, by and large a hard time to tell anybody anything. When people are depressed, it's sometimes possible to do like an intervention like you would with alcohol or drugs and sit down and say, get a group of friends and colleagues and, priest or rabbi, whomever, and sit down and say, look, we're really concerned about you. Be very specific about what it is you are concerned about, so it's not some sort of just general paranoid inducing, we're worried about you. But, I mean, we're worried because you're doing this, that, and the other thing. And if it looks like an emergency, we've made an appointment for you, or we're going to walk you over the emergency room. But because you have a capacity to sway with numbers that you cannot do alone. I mean, if you're one person with somebody who's depressed, moods are contagious, so the odds are you're going to end up being depressed because the hopelessness is so contagious. And you're not going to persuade, because when people are hopeless, they think there's nothing that can be done for them. Yes, it may be treatable, but that's for somebody else, or how do I know the doctor's as smart as I am? Whatever the rationale is, hopelessness doesn't make it people seek care. If you have more people involved, sometimes that works. Sometimes.
Hi, Dr. Jamison. Thank you for your frank, candid description of your suicidal thoughts and your suicide attempts. Here in Colorado, we're faced with our young adults' leading cause of death is suicide. From your perspective, what do you think that we can do better for our young adults and kids and adolescents who are struggling, likely with a mood disorder that hasn't been identified yet?
One thing is the Western states, of course, have very much higher gun ownership. A lot of suicide is impulsive. In adolescence, it's particularly impulsive. So if you don't have access to a gun, it's not the case that you're then going to just go off and, go off a bridge. The research doesn't suggest that. The research suggests that it's really, capacity nearby and near at hand. I think, in the last couple of months, people have begun to say enough's enough already. I mean, there were people in Florida, doctors, who could not ask their patients whether they had a gun in the house or not. A group of us put on an emergency room poster after somebody came in suicidal or after a suicide attempt for doctors sort of to check off things. One of them was, does the patient have a gun in the house? I can't tell you what kind of flack we got. Okay, this is simply unacceptable. I mean, people die from guns, and so if you've got a gun in the house and you've got somebody in the house who's suicidal, get rid of the gun. Put it someplace else for 5 or 6 months. And I think that actually counts for a fair amount of suicide in young people. And I think you've got a governor who seems to be very dedicated to mental health issues and to the issue of suicide. I think it takes awareness. It seems to have been ticking upwards, and why that is, all sorts of suggested reasons. But, I think obviously trying to get kids educated early on, I mean, I don't think you want to go in the school systems and start talking about suicide. I think there's evidence that that's probably not a good idea. But what you do want to do is very early in the schools to teach kids about depression. What do we know is most associated with suicide? It's depression. So you want to go in So Karen Schwartz at Hopkins, for example, has started a program a long time ago, and now it's a national program, but it's a program for middle schools and to teach the teachers, the parents, and the students just the symptoms of depression. No big hoopla, no big discussions about anything else. Just these are the symptoms. A lot of you are going to get this, really treatable. What can we do to help? Sort of thing. Just a very straightforward, and it's been very effective in getting kids into treatment. It should be easier. We don't devote the resources to it. I mean, every school has a different program, as best I can make out. So there's not very much systematic research on this, on what really works. People just kind of go in and think if they, after a kid commits suicide, for example, in a school, that you just have somebody come in and talk about suicide. That is not going to prevent suicide, So it's big problem. Big problem, I know, in Colorado. It's a big problem in unfortunately, a lot of America.
Dr. Jamison, you mentioned a couple times your level of satisfaction with your own provider. And as a future provider myself, I value that alliance and continuity with my patients. And one area I fear, maybe semi-selfishly, is that violation of trust when you have to come to the point of putting a hold on a patient or testifying against them in front of a judge for a certificate. And I was wondering in particular about the inpatient experience as a patient. Because certainly from my very short experience as a learner, it in some cases seemed counterproductive and possibly destructive. And I understand that death is definitely less productive, but I was wondering if there are, innovations in the inpatient experience, and if that loss of trust is regained with your provider after an acute exacerbation.
Right. Well, a couple of things. One is, I think it's not that you can't consider trust. You can do everything possible to keep somebody out of a hospital and explain to them why you are putting them in the hospital. But at the end of the day, it's got to be whether or not they need to be in the hospital. Okay, in this day and age, it's pretty hard to be admitted into a psychiatric hospital. You have to be really pretty sick. When you're talking about average lengths of stay of 2 or 3 weeks, it's a legitimate question. What gets done in 2 or 3 weeks when we used to have a year or 6 months? One is safety, that people who are acutely suicidal can get evaluated and keep from killing themselves. I mean, now people do kill themselves in hospitals, obviously, but at a much, much lower rate. One is getting the diagnosis right, having a chance to observe people. I mean, the number of people who just are on all the wrong medications for all the wrong diagnoses is really staggeringly high. So an inpatient stay allows people to see people up close, interview a lot of family members, interview friends, and see what's really going on and take a really thorough history, okay? Not just kind of an outpatient history. So I think the thoroughness of the opportunity, likewise with mania, people are dangerous to themselves and to other people. So you can't have people like that just wandering around. It doesn't make any difference whether they don't trust you anymore. They can't, just ruin their lives or, assault other people. They need to be protected, and other people need to be protected. So, it's unpleasant, but I think that's one of the hard things. I mean, that's part of the job, is doing unpleasant things, unfortunately. And then you have a lot of time to try and make it up, and they may just say, I can't deal with it. I can't deal with you, in which case you've done what you thought was right, But I think sometimes if you have a patient who's been hospitalized before or made a serious suicide attempt before, one of the things that you can do is not in the midst of an emergency or in a crisis, but ask them when they're well, what did your doctor do before that was helpful? What did the doctor do that wasn't helpful? What did your family do that was helpful? What did the family do that really agitated you? What would you like done? Under what circumstances? That takes away, again, the onus of trying to make decisions when there's a lot of stress involved. And how would you like it? If you need to be hospitalized, again, it's going to be difficult. And, call it, predict it and say, this may happen. I hope it doesn't. But if it does, you're going to have to understand that I have to look out for you. But good luck with it. Yeah. Well, I think there was a long period of time when lithium was the only drug that was used for bipolar illness, and it was regarded that, you had to take a woman off during pregnancy. I think people have come a long way from that, realizing that a couple of things. One is that the mother's health is extremely important to the mother, and the mother's health is extremely important to the child. So if the mother starts getting manic and drinking and smoking and staying up all night and stress hormones are going around 100,000 miles an hour, that's not good for the developing fetus. So people, by and large, if somebody's got bipolar 1, the more severe form, people tend to stay on their medications. Bipolar 2 is perhaps a little bit iffier, but there are real risks in coming off. And one of the things that we know about lithium is it takes quite a while to build up a therapeutic level that is stabilizing. We also know that if you withdraw lithium, the odds of you getting manic within 6 months or committing suicide within 6 months go up very precipitously. So these are, I guess what I'm saying is, these are very much questions for a specialist. So if somebody, a specialist who is going to understand the history of the woman, understand the medications, the timing, the titrating, the kind of the observations that need to be made. I mean, people do it all the time. The simple answer is people stay on medications a lot and have perfectly normal kids, but it's not the sort of thing that you, I think, don't want to have checked out by somebody who's a specialist.
Thank you, Dr. Jamison, for doing this. I have a question that may not have an answer. I'm thinking about all the contributions you made in so many different areas. As a teacher, as a clinician, as a writer, and more. In which of those areas give you the greatest sense of satisfaction having made a contribution?
Well, it's nice of you to say. I would say, I would guess through writing. Mainly I like to write, and I think I made the decision before going public of whether I said it just in an interview or if I wrote it, and I decided I wanted to write it because I think writing things has more lasting impact. I mean, I'm a brontosaurus. I actually believe in books. So I would stick by the books. Yeah.
Hey, Dr. Jamison, over here to your right. Hi. So I just want to say thank you for coming here and speaking with us today. And so I just wanted to ask your advice, actually. So I'm a medical student here. I have a friend who suffers deeply from bipolar disorder. And personally, I find it very difficult to sort of find that line between being a friend and, in some ways, acting like a provider almost. So I wanted to hear your thoughts on, for the future providers in this room and the current providers, how to sort of strike that balance between, sort of compassion. I'm not sure what the other word is, but like compassion and sort of efficacy or effectiveness in treating like our patients and our loved ones.
I think the greatest compassion generally comes from truth. with warmth and caring, but I'm not a great believer that weaseling around, you might guess, should probably weasel around a little bit more, but that really is very effective. I think most people will see through that pretty quickly. I think that if I look back at my friends or my husband or my late husband, I would say there's a certain amount of genuine compassion, love, intuition, and toughness. I think toughness goes a long way, as it does in doctoring in general. I think being willing to make tough decisions, say tough things, and do it in a way that conveys that you care and you're not going anywhere, but that you're still tough. I mean, I remember asking my husband once what he did with patients who had terminal cardiac illness. I said, when you realize that your patient's going to die, what do you do? What do you say? And he said, I sit down with him and I say, I'm going to be seeing you more often. And the implication, he says, nobody takes it for anything but that this is a grave situation, that, we're going to be looking at different medications and so forth, and it's going to be tough. But the overall message is, I'm not going anywhere. And I can tolerate whatever it is you're going to go through. This is, because that's not always clear in doctors, I think. I think doctors are like everybody else. There's some who are very tough and very able to deliver bad news, and there's some who kind of move out of the room, as it were. So. Thank you. Thank you.